Good afternoon, and welcome to the Center for Global Development. Because we're videotaping the event, I'm going to be formal and talk into the mic, even though we're a small group and we can all hear each other. My name is Justin Sandifer. I'm a research fellow here at CGD, and we're delighted to have you all here at the Massachusetts Avenue Development Seminar. MADS is a monthly event that we host here at CGD. We bring in external experts to talk about a wide range of development issues. And today we're very excited to have Dr. Gilbert Burnham from the Johns Hopkins Bloomberg School of Public Health. He is co-director of the Center for Refugee and Disaster Response there at Johns Hopkins. Dr. Burnham began his career, I think, in Korea, drafted as a conscientious objector and did medical work with burn victims in Korea. Moved on to running a hospital in Malawi, where he began doing research on river blindness, something he's continued to do throughout his career. He holds an MD from Lomlanda University and a PhD from the University of London. And some of you will be familiar with some of his more headlining work, estimating mortality rates after the invasion of Iraq, a 2006 article in Lancet. But for the more development economics set that frequently comes to events here at the Center for Global Development, he's worked on issues like scorecards to improve health service delivery in Afghanistan, user fees and access to care in Uganda. So projects from North Korea, China, East Africa, Afghanistan, Iraq, and kind of around the world. But we're really excited to have him here today to talk about the situation with the health sector in North Korea. Obviously a very difficult topic on which to do primary research. So we'll leave it to him to explain the challenges of methods there. In addition to Dr. Burnham, we're also privileged to have Roberta Cohen as a discussant here today, who is a non-resident senior fellow at the Brookings Institution. That's how she told me to introduce her. She didn't mention that she also co-founded and co-directed the Brookings Institution project on international displacement. So she is a renowned expert in this area, and in particular has been working in recent years specifically on North Korea. She was also senior advisor to the representative of the UN Secretary General on IDPs from 1994 to 2010. And she is currently vice chair of the Committee for Human Rights in North Korea, which is a nonprofit based in DC, which pushes to link development assistance to North Korea to tangible improvements in the human rights record. She's published a number of articles and op-eds on human rights in North Korea in the Washington Post, the New York Times, and most recently the National Interest with Mort Abramowitz on Kim Jong-il and the hunger problem. She holds an honorary doctorate from the University of Bern in Switzerland and an MA from our neighbors here at SAIS. So we're really lucky to have her to add a policy angle on the implications for the North Korea policy debate of Dr. Burnham's research. All right, with no further ado, we're going to have about 45 minutes from Dr. Burnham and then about a 10-minute discussion from Ms. Cohen, and then we'll open it up to Q&A from the floor. So over to you.
All right, thank you very much, Justin. And I hope I'm not going to talk too long because we want to hear from Roberta as well. And so what I'm going to show today are data, some of which we've collected ourselves, a lot of which has come from other sources, some of which are stronger and methodologically than others, and then a lot of kind of ad hoc understanding of what's happening. And the pictures I show, some of them are my own, like this one, and many of them are, like most people do, shamelessly appropriated from the web. I've tried to give a bit of credit here and there. So let's talk about health inside North Korea. Now this is very much wound up with issues of nutrition, issues of water and sanitation, issues of access, a lot of political issues, a lot of economic issues. It's all kind of wound up together. And in none of these areas do we have the kind of adequate understanding that we would have when we tried to understand circumstances in other countries. So a little bit of recent history. The economic differentiation between DPRK and South Korea really became much more obvious in the 1980s, probably even in the 70s. This decline in North Korea accelerated, of course, with the collapse of the Soviet Union and the loss of access to cheap energy. The issue that I think put North Korea on the map for many people was the serious food crisis in the 1990s, blamed very much by the North Koreans on storm damage to the land and to the agricultural sector, but analysis really shows that the whole country was affected, and those areas that supposedly had the heaviest storm damage weren't really much different than the other areas as well. So we have to look beyond that excuse to what was really behind it. And then this very difficult time when there was a large-scale starvation and death, which various people have estimated in various ways. Subsequently, a massive supply of food to the agricultural sector, and in fact, for some years, North Korea was probably the largest recipient of foreign assistance in the area of food. From this event, agriculture has never really fully recovered. There are still chronic problems with the distribution, the public distribution system that many people depend upon for survival can only deliver maybe half or 40 or 60% of the kilocalories that are required to function. And food insecurity remains as a major problem. There was a period where there was economic liberalization, and that did seem to change the access to food, but then more recently the economic reforms have seriously damaged coping mechanisms. This looks at the figures for North Korean resettlement in South Korea. You see there was a bit of lag from as South Korea developed economically, and then gradually we have seen this number increase. So it's estimated that now there are probably in excess of 20,000 North Koreans living in South Korea. And if we look, interesting enough, and I don't want to talk about this part of it, we look about, this is the line for males and this is the line for females. This is really evidence of trafficking in many ways, and that's another topic that can be discussed at length. Where does that information come from for this? Well, probably the best data set any place comes from World Food Program and UNICEF, which did surveys in the early part of this millennium, probably 2003, 2002. Fairly good data sets from that. Now, was there a chance that the samples were manipulated? Very much so. Was there a chance that certain populations were excluded? Absolutely. There were parts of North Korea that were considered high security areas where the teams were not allowed. However, the general feeling is that imperfect as these data are, this probably represents a fairly good picture, fairly reliable picture of what was actually happening around 2002 to 2003 in the food sector. The North Korean government provides data on a regular basis. There is no doubt that this is manipulated, sometimes manipulated down, sometimes manipulated up, depending on what the advantage to the country might be at the time. There are quite a bit of NGO data, and we have actually depended on some of the NGO data collected across the border, which I'll mention in a minute. Much of this is advocacy-oriented. This is, in many cases, not collected in a scientific manner, but it does provide a picture. And increasingly, there are civil society sources. And those of you who saw the Atlantic Monthly fairly recently read about how various sources in North Korea are being utilized to provide information on at least small vignettes about what's happening in specific areas. And then there's the kind of thing that we've been doing quite a bit of, and that's the cross-border monitoring. That is people coming into China and then interviewing them, collecting data from them, and we've just finished another data set about a couple weeks ago of 370 North Koreans that had just come across the border in the last couple of weeks, trying to get a sense of the health system and health services, and we'll talk a little bit about that later on. Highly selective. Any other situation, you know, nobody would pay much attention to this because it's not really a representative sample. But when you don't have anything else, it can add to the overall picture of what we understand. So here's one of them, North Korea Today, from Good Friends. That's one of the sources one looks at. This is stuff that we collected starting in 1997, I think, actually. This is the Tumen River, and here it is frozen. This was a time when people were walking across. So if you're collecting data in this area, you collect it from about November through March while the river is frozen, and then when the river thaws out, the number of people crossing goes down substantially. And much of the information we collected originally came from various churches. Here's a church within 700 meters of the river, and this was kind of the first stop for many people coming across the border. So the churches have played a very important role in providing assistance, and I'm happy to say for us, also in providing data. So we train members of the congregation how to collect data and so forth. Again, fairly selective kind of process, but still a good source of information. If we look at where the population is in North Korea, you can see mostly it's along the coastal areas, and large parts of the central part of North Korea is really devoid of much in the way of population, really low population density. So kind of skewed in a few particular areas. If we look at South Korea, you know, we see much more homogeneous area for the population, spread around much more widely than in North Korea. If we looked at arable land and where things are grown, the green area is forest area or a mountainous area, and the light brown is scrub area. The darker brown and this color brown, whatever that color is more arable land. Now this is 22% of the country is arable land, but by contrast, South Korea, 19% of the country is arable land. The rest is all covered with motorways, for those of you who've been there recently, and also the fact that if you're a strong economy, you can import food, and that's not a major concern. This is something really interesting. This is kind of the thing that we look at a lot in demographic studies, the population pyramid. And it looks at females on this side, males on this side, different age groups here. And there's some things that are really interesting in this picture. We can see right here that there was obviously a fertility spurt after the Korean War. So this probably represents babies born after the Korean War. And not surprising, this kind of thing happens frequently after conflict. We have something else here. Now, this is about like 15 or 20 years ago. So does this represent a population spurt, or does this represent the end of high fertility rates? Because you can see now the fertility rates have dropped off dramatically subsequent to that. And the other thing that's really interesting is look at this older population, male and females. Females are much more represented in the older population than males are. There are probably a number of reasons for this. One of the facts is that 58% of males in North Korea smoke, so that probably contributes a bit to it. But we also know that in food insecurity and famine situation, women always do better than men. Now, why that is not clear. And it's not only older people, but it's also young children that do better, that the women do better than men. There's some biological issues that yet have to be teased out. Now, if we look at where life expectancy is now, for men it's 65 and for women it's 69 years. So there are many countries where this could be fairly representative of the population. But what's really interesting to look at is what was population life expectancy in 1993. So you can see both for males and females, things have gone backwards, perhaps similar, maybe more for women than for men. And so it can't all be based on the fact that there are more men smoking now. So there are clearly many other issues. And when we look at the health of the population, things about nutrition rates, things about life expectancy, things about deaths among children in the first year of life and the fifth and up to age 5, these are some of the key indicators that we look at that give us an overall picture of what's happening to the population. So you can see right away the evidence is population's in serious troubles. No doubt. Fertility rate, this means the number of children that a woman will have during her whole lifetime. It's now 1.8. And interestingly enough, that's about the same or slightly higher than South Korea. Now, the reasons why fertility rates have dropped in South Korea and why they've dropped in North Korea are probably, I'm guessing, for completely different reasons or somewhat different reasons. But we could talk about that later on. Okay, here's population growth, and you can see, like many countries, Now, South Korea, the population growth doesn't quite look like that because people are living much longer. And so that can increase your overall population size. But here we see that population growth has been pretty steadily dropping. And estimates, and these represent estimates based upon, like everything else we're talking about, not the kind of complete data you would like before you stood up in front of the microphone and spoke about situations in Bosnia or something. So let's talk about the agricultural sector and the food security issues, because these are the things that really dominate our discussions on North Korea. Now, I'm not so interested in this from the aspect of how many bushels or how many metric tons you get per hectare of land. I'm interested in this from what it does to the population and how you can measure that kind of impact. This is estimated to be, this is estimate to be what the production of cereals and imports in DPRK by year, and these are the imports. And even with this, probably adding it all up, it's only about 70% of what the country really needs. This is something very recent from World Food Program, looking at various provinces, and within those, which counties are producing surpluses and which counties are producing deficits. And so you can see a lot of deficits going on. Some of this may be related to the heavy rains that occurred end of last summer, but some of it just dealing with declining production. And this was an interesting study, totally not representative. You can see we have probably only about 200 and some households in this. This is World Food Program, and in 3 counties, which they were allowed access to, they did interviews about food consumption. And dietary studies, anybody who's done dietary studies, these are really hard to do because most places, most countries, nobody can remember what they ate 2 or 3 days ago, you know. So unless you had serious indigestion from that Big Mac that you ate. It's kind of hard to remember. But looking at this, if you were on a farm, cooperative farm, 69% of the diet was rated as poor. In 24% of households it was borderline, and in 7% of households it was considered to be acceptable. And interestingly enough, if you were getting food from the public distribution system, things actually look worse. And here we have a bit of difficulty with some conflicting data, because historically, analysis of trends have shown that people who were getting food from the public distribution system, especially if that food was of foreign origins, did better than those people who didn't. But for these kind of data on an unselective sample, it actually looks a bit worse. So what does it mean to have a poor diet? So a poor diet means that you had oil, well, you had some basics, some kind of tubers like potatoes and cereals and vegetables. So everybody had those. But if you had a poor diet, you had that plus twice a week you had oil in your food. If you had a borderline diet, you had the oil, but you also had some additional legumes, or animal proteins maybe twice a week, or sweets or sugars maybe once a week. And if you had a really acceptable diet, kind of the Maxime's diet here, you had animal protein twice a week, dairy products in addition. So if you're below the acceptable level, you never had any milk or cheese or yogurt or anything else. And you had more oil and you had a lot more sugar. You had it like twice a week. So this kind of gives an idea about what an acceptable diet looks like from the World Food Program and the kilocalorie and basic requirements. So in spite of the propaganda posters, you know, this is not a very good diet. Now, how does this play out? Well, when you're on a bad diet, a couple things happen to you. One of them is wasting, and this is acute malnutrition. So it means that maybe you were making it okay until a couple months ago, and then things really deteriorated, or that things have been sliding downhill pretty steadily. And these are the kind of pictures you think about, whether it's here, whether it's in Ethiopia, the acute malnutrition. Now, one of the problems is we can't always predict in a food crisis situation who's going to get wasting and who's just going to get seriously underweight. So the other side of things, and this is much more important when we think about the North Korea aspect, and that is stunting, the inability to reach your full height. Of Okay, here's some examples of stunting. This was last August. Of course, it's squished a bit here. But this is the one I like here because this is about 4 years ago in Najim in the north. And this fellow here, his parents came from this area of North Korea, but he grew up in Orange County, California with Orange County diet. So he has the same DNA as the handlers here, but he has Orange County diet. So it's just as a good illustration to how diet is so important in your growth and your stature and so forth. Okay, this is an interesting graph, and this is updated, and it doesn't look much different than it did in 2004 when these were collected, of the amount of stunting, the amount of wasting, that really wan look, and then the amount of underweight. And so you can see it varies across different provinces, but like most countries, people who live in the capitals do better than people who live in the other areas. And of course, those of you who have been to Pyongyang, you know this is kind of a showpiece, and so people get to go there because of some kind of loyalty or some kind of attributes that they have. And so, not surprisingly, they have done better from the nutritional standpoint. And this is what we found from a couple studies. Children in households who received foreign food, as it's called, or international food, they had less malnutrition. And we also know from that article in The Lancet that households that got foreign food had less mortality than those who didn't. So there is a direct effect on the households. Now, we also know that if you had somebody who was in the party, or if you had somebody in the military, you got more food than if you didn't have that. So that's a kind of a confounding variable there. But we do know from the data that food is indeed reaching people. Now, how much of it gets siphoned off for the military and the elites and so forth? Yes, I'm sure it happens. But anyway, in the system, it does seem to get down to people, and it does seem to have an impact. Now, this is interesting because this is malnutrition by age. So here you are 11 months. So you can see already at 11 months, there are children who are wasted. There are children who are stunted. So already. And then as time goes along, the stunting gets worse and worse and worse up until about 5 years. Underweight's not such a good indicator. Here, the wasting, this doesn't look bad compared to many countries in Africa. But what this graph means is people are getting kilocalories of some sort, but they're not getting the level of protein. And they're not getting many of these other nutrients that they need. And this is interesting because this is exclusive breastfeeding. And this is an important precursor to good growth. So if you start life not being exclusively breastfed or well breastfed, then you're likely to develop stunting. And so we've seen, again, maybe somewhat selective data, but we've seen this drop dramatically. Now, you could read into this lots of economic events and other things happening that means that women are separated from their newborns for a longer period of time than they might be in other circumstances. So I don't want to make much more out of that except to see this is a dramatic change. And most of the rest of the developing world, you see it going the other direction. Okay, a reminder that malnutrition, this is worldwide figures, malnutrition is a factor in about half of deaths of children under age 5. So if you're dealing with a population that has serious nutritional problems with its children, you can be sure that malnutrition is playing a major role in this elevated death rate. And looking at this, this was a picture I took in the hospital in Pyongyang. Perinatal, which means in the first few days of life, accounts for about 18% of deaths worldwide, and I'm convinced in North Korea it's much higher than this. And again, nutrition is a problem, not just of the newborn, but there's something called intergenerational nutrition. Big word, meaning if your mother's not in good nutritional state, then the baby won't be in good nutritional state. So that's why those of you who've been pregnant, something that hasn't happened to me, but those of you who've been pregnant know the doctor is always saying, how much weight have you gained during pregnancy? Be sure it's not too much. Be sure it's not too little. To be sure that the mother is adequately nourished to support this baby coming along. And the data that we do have from UNICEF suggests that half of mothers, these are mothers with new children, newly born children, half of mothers are underweight. So we know this is a major issue. And we also know that someplace between a third and half are anemic. So that means that they're not getting probably enough iron, they're not getting other kinds of nutrients they need, not only to keep them happy, but in order to keep the baby growing well. And then we look at maternal mortality ratio. All right, don't worry about the terms, but this means how many mothers for every 100,000 births, how many mothers will die as a consequence of their pregnancy, some way related to their pregnancy. And here we see in 1993 it was 54, and now it's 77. So this is a big, big red flag in the public health world. There are major issues that are affecting the pregnancy of women. So big, big issue there. And here's something we look at, which we call infant mortality and childhood mortality. So this means out of every 1,000 children born, how many die by the first year of life and how many die by age 5. So this is the pattern starting in 1993 of children dying in the first year of life. So you can see this has been steadily rising, reaching the level of many African countries, and the estimate for 2008 is 67. Now, this is of great concern. Now in the U.S. it will be about 8 or 9, some places 7, except in Mississippi, which has been steadily reducing assistance to pregnant women, where it is now about 13 or 14. So that gives you kind of a benchmark for that. And now this is a pretty well agreed number. Even the information coming from the North Korean government supports that. This is number of children dying this is under age 5. This is a number in the first year of life. So you can see that's been steadily rising and is estimated to be 48 in 2009. Now that's a major concern, and this data is not agreed. There are many different figures here, but this is one of many that looks fairly reasonable. But by any account, however you measure it, children are doing much worse in North Korea than they were in the past. Okay, now these are data from our work in 1999, and we looked at death rates across the population. And this is from the 1993 census that the World Health Organization helped DPRK do. And most people think this is fairly reasonable estimation. And high death rates in the young and then dropping and then gradually increasing with years. Now this is what we found from our data, fairly selective, people coming across the border. But just to note, this is a log scale. So this is 1, this is 10, this is 100. So if we plotted this out on a non-log scale, it would be a much bigger difference. And what is dramatic to me in this is that death rates are raised at all age groups, especially in older children. When you start seeing elevated death rates in older children, then you've got a really serious food crisis going on. And I think that shows that. Okay.
In the mid-1990s, natural disasters and government mismanagement created a famine that killed up to 3 million people, about 10% of North Korea's population. Taking place in the heart of prosperous East Asia, it was one of the worst famines of the century. Today, nearly 40% of North Korean children remain chronically malnourished. The average 7-year-old boy in North Korea is nearly 20 centimeters shorter and 10 kilos lighter than his brother in South Korea.
But I say the damage to his bones is permanent.
Okay, just a little video clip to kind of emphasize that, and that's the thing that strikes you visiting North Korea is how many small people there are. And the thing that strikes me visiting South Korea now, and I've been doing a series of lectures at various universities in South Korea, is how many tall people there are in South Korea compared to what I remember when I was a young army doctor in Korea. Let's see if I can go. Okay, so let's talk a little bit about health services in North Korea and health status more specifically rather than just kind of the nutritional side of things. This is what the health system looks like, multiple levels from national level down to the neighborhood level. And at the neighborhood level, there's been this idea that there's a section doctor. And this is a doctor may be based in the clinic or polyclinic, but has responsibility for 130 or 140 houses and visits them on a regular basis. At least that's how it's set up. All the information now suggests this is all falling apart, and that's not happening now. Red Cross volunteers, a lot of Red Cross activities heavily supported by the International Federation in Geneva. Community work teams that go out and do sanitation and clean up things and so forth. So those seem to be functioning. At the next level, the sub-county level, there's the polyclinic and there's the midwives. Polyclinics seem to be working variably. Some places they seem to work fairly well. Other places they don't seem to work at all. So it varies. And one of the reasons probably is that people are wanting to bypass this to go to the county hospitals or the provincial hospitals. This idea of bypassing the small clinic and going to the bigger one, this is a universal problem. So I don't know if we can say that there's some special structural issues that have caused it in North Korea, although you can think of things that might aggravate it there. Every area is very concerned with epidemic control. And indeed, North Korea is having a lot of problems with epidemics. Epidemics that would be totally controllable in other situations. So a lot of effort has to go into this control, and the control method commonly is quarantines. You know, we stop travel from this place to you can't go here, you can't go there. Now those of us in public health know quarantines never work very well, but that's a very common thing that are used. And then the provincial hospitals, which are much more in the way of a specialty kind of hospital. And then finally, the Ministry of Public Health, which actually is part of the Ministry of Internal Affairs. So it's not a freestanding ministry fully on its own. National Hospitals and the Red Cross. Now, this is how much North Korea is reportedly spending now on health. So around $1 per person per day, lowest in the world. Now, when you calculate this, of course, there's a lot of missing data, and you're always having to deal with exchange rates and purchasing parity and so forth. So it's really hard to come up with this exact figure, at least in my mind, but this is what's quoted, and certainly it's extremely low. I think we would agree there. Health structure, probably about 800 major hospitals, 1,000 hospitals at the community level, lots of polyclinics, huge number of health workers present. So it gives you an idea comparing North and South. The North has huge numbers of doctors, 3 times, maybe twice as much, as the South. Same thing for nurses, hospital beds, so forth. This is all actually a sign of weakness rather than a sign of strength. And we could talk about that more. This is a national maternity hospital, and there is supposedly a maternity hospital in every province. This one is a showpiece, and that's why I got to visit there. This is a county hospital. Comes down substantially in levels, and it was hard to get a real picture of what was happening going through here because there was no electricity that day. This is a typical picture that somebody else took of a county hospital. Not surprising. Every place there's an emphasis on nutritional rehabilitation for various reasons. Tuberculosis is a huge problem in North Korea, as it was in South Korea 30 or 40 or 50 years ago. And here's a doctor using a very old-fashioned method of screening the chest using fluoroscopy, and this is because there's no x-ray film. And the consequences of this, reportedly, is a number of doctors have eventually gone blind from the effects of the radiation. This is what we're looking at, new cases of tuberculosis, and many people feel this is seriously underreporting. Now, we have a huge problem with tuberculosis that's resistant to drugs. And this is because people will take the drugs only long enough to feel better. And since you can only acquire the drugs in the markets, as soon as you start feeling better, then you stop buying additional drugs. Although World Health Organization is giving the drugs free to North Korea, to the health system, it never gets to the people. It's always taken by the health workers and sold. So this is a big problem, and probably this is the reason that China is really frightened about what's happening to tuberculosis inside North Korea, because once that you get multi-drug resistant tuberculosis in your country, you are in big troubles. Now, there's a group in Ellicott City that actually work, the Eugene Bell Foundation, that actually works directly with people who have multi-drug resistant tuberculosis. Complicated system, but they deliver the drugs directly to the patients and say, okay, here is a year's supply of medicines. Now, that doesn't mean that people don't sell their medicines in North Korea just like they do in other parts of the world, but at least it's an attempt to try to get the medicines directly to them. Okay, this is the intensive care unit in the maternity hospital. Looks quite nice with good equipment and so forth. This is the nursing station in the county hospital, you know, a couple light years away from that. Fancy Siemens equipment in the maternity hospital. No patients. I didn't see many, well, but not many patients, but a lot of impressive looking equipment. This was the X-ray unit in the county hospital. A fairly reasonable unit, adequate to needs, except there was no electricity. And this was the laboratory at this National Maternity Hospital, which, according to my calculations and their numbers, should have about 300 patients in the hospital. And this was, I went through here in the middle of the afternoon, which is a busy time in any lab. There was not a single specimen being processed in this lab. So I think Pyongyang, you could kind of classify it like this children's game of looking at something and saying, what's wrong with this picture? You know, something is not right. And what it is, you know, sometimes you don't know. Okay, it was the operating room in the county hospital. Not looking so good. This is the medical university in Pyongyang, and the hospital that goes with it. Quite an impressive entrance anyway. I tried to get our handler to take me in there and have a look. I tried to convince her that her elderly uncle was sick there and needed her visit, but I didn't have any success. Okay, so health among children. Diarrhea and respiratory infections, major cause of death. This could be the Congo as well as it could be there. Maybe 31% of children with low birth weight. So that right away shows mothers are not getting nourished well. We said this already. There's probably high vaccine coverage, and that's probably okay. But there's still problems with measles. And if you have measles in a country that has bad nutrition, you're just asking for troubles. That is just an unholy combination, and it's a high cause of death when that happens. So this is UNICEF data on why children die. So prematurity, major cause, as we've said here. Congenital abnormalities are interesting too, because one of the problems that one has is women who do not get enough folic acid or folate during pregnancy, the babies end up with major spinal defects, and that may be what's happening here. In the wintertime, how much green vegetables do you get in this type of situation? Okay, street children. Street children, as many of you have seen, is an increasing problem. This is something a number of advocacy groups have looked at. Methamphetamine is becoming a major issue in North Korea. And there are rehabilitation units at some hospitals trying to help people get out of methamphetamine. This is a clandestine view from a Japanese TV. Showing some of the street children, homeless people living on their own, and this has been documented fairly extensively. And among the civil society groups that report on this, this is a very common focus and a common report that one sees. So major kind of issue, this population. Water and sanitation, another thing that contributes very much to health, huge problems in these locations. And these were households asked, how often do you have access to water? And so most people had access less than 6 hours a day. So this is an issue. Here's where many people get water. If you look at this well, I can see 5 reasons why that water is going to be contaminated. Children carrying water, one of them has a covered container, the other one's open. Children are really spectacular at contaminating water. They've got so many contaminants they can put into water. Surface water, by definition, is contaminated. Anybody collecting that's contaminated water. UNICEF has put quite a bit of work into aid schemes and trying to provide gravity flow into some areas. Same thing with sanitation. 90% of population used, and this is not a representative sample, 3 counties using pit latrines, which might work okay. Common diseases, hepatitis, major issue, and commonly it's reported as a cause of death. Typhoid, paratyphoid, dysentery, scarlet fever. That's disappeared from the rest of the world. But if you have antibiotics, you don't have to have an epidemic like this. and then increasingly with older population degenerative situations. This is just an interesting little clip from this this Nepalese eye surgeon who's been making frequent trips to North Korea.
It takes only minutes to replace each lens. But with more than 1,000 patients waiting, Dr. Root's team needs to treat more than 100 people every day. In the developed world, cataracts rarely get so bad, especially in young people, that they result in blindness. But here, because of poor care and likely poor nutrition, the incidence is as much as 10 times higher than in the West, and afflicts young and old alike. This woman is only 35, and her blindness has kept her from marrying. And this woman has been totally dependent on her husband for years. The demand here is enormous, but in North Korea, cataracts are only a small part of the humanitarian nightmare. The moment of truth comes first for a 23-year-old woman. She's come with her father and has been completely blind for years.
Ask her to open her eyes.
자, 눈 들어요.
Yeah?
눈 들어요. 보여요?
Can she touch my nose?
코 다치라 네 손으로, 네 손으로.
Where is your? Ask her where is her father.
아버지 어디 있나 여기?
여기 있습니다.
은희야, 내 보이느냐?
네, 잘 보입니다.
진짜 보이니?
네.
위대한 당구님의 덕분이구나. 우리 당구님께 큰절을 드려야 한다. 우리 당구님 정말 고맙습니다.
이 자리에서 아버지 장모님께 감사 인사를 드리고 싶습니다.
위대한 연사 김정일 원수님 정말 고맙습니다.
Okay, just give you another kind of interesting little vignette of the health system. H1N1 was a big problem. South Korea tried to help with Tamiflu, but it never got out of Pyongyang. And many people apparently died because of isolation. They were isolated in some of these high-rise apartment houses without elevators, without electricity, and it's also a problem with hypothermia. Okay, I want to just finish up here. I could talk a little bit about the hospitals. Medicine now is almost exclusively in the markets. It's almost exclusively from China, and there's a lot of problem with counterfeit drugs in this area. Health workers looks good, but educational status is poor. Of the medical personnel defecting to South Korea, very few can pass South Korean examinations because of the quality of things. People spend a lot of time raising food. This was a railway yard that I took a picture of the railway yards growing food there in the spare spaces. Shortage of medicines. Oh, this is something we did a couple of years ago on health-seeking behavior. What happens when you get sick? And let's see. Everybody had an official job, but many people had unofficial jobs like retailing here, and this was a common source of income. This was household income that we measured in our set of people in China, maybe $43. Again, problems with the exchange rates and so forth. Many people were sick. 80% of households had somebody in the hospital in the last year. And average length of time was 30 days. So huge problem. Then we asked where people got their money from to pay. Oh, this is what people were in the hospital from. So lots of infectious diseases, injuries, and so forth. And people, if you went in the hospital, you had to pay. Everybody had to pay, and you had to borrow money to pay. 90% of people reported gifts to the doctors, and this is how much you had to pay. So if you were a farmer, you were paying 140% of your monthly household income and gifts to the doctor to get care. Satisfaction, nobody was satisfied with services. There was no hesitation in saying that. I'm going to skip through the last of these things here. But the outlook is things are going to continue to deteriorate. The market will continue to provide medicines because everybody is profiting from the market. The military conveys things. People get bribes to allow the markets to continue and so forth. So in spite of all the efforts, that's going to continue. Flooding, natural disasters will continue. And where's the future? Well, it's around the corner, and we don't know what it is. So, Roberta, I've gotten into your time here, so I apologize. So let's talk to you, let you talk, and then we'll see if we'll take any questions or comments.
Okay. I'm going to go sit here. I don't have a...
Here, I'll give you this one. Here.
Oh, either way. Pass the baton. It'll help the video pick up your, even though we can all hear you in any case.
If people here want to come sit at the table, it's sort of nicer. Thank you.
There you go.
Should I just stick this on me? Okay. That was really a terrific talk. I have to tell you, I could have listened much longer and seen your show here. I just want to say very quickly that how I got into the subject even of North Korea has to do, which you probably don't know, with Johns Hopkins and the World Food Program, with UN agencies. It was in 2000, and I was organized a conference in Bangkok. This was going to look at internal displacement in all Asian countries. And somebody was coming from China, and someone was coming from all different places. It was a non-governmental conference. But what did we do about North Korea? So I asked the World Food Program if they would like to send a representative to comment on this. And they came back and said that there is no such thing as internal displacement in North Korea, even though we've just seen pictures of homeless, and there were the flower children after the famine. And not only was there none, but we shouldn't talk about it, and it shouldn't be on the agenda. So I put it on the agenda, and I turned to Johns Hopkins, Court Robinson, your colleague, who came out and wrote the first article on internal displacement in North Korea. Quite courageously, and good friends came as well. So somehow this information issue and the role of international organizations, I think, is relevant to some of what you're doing in my comments. My comments will focus more on the policy and the politics surrounding healthcare in North Korea, rather than the methodology used by Johns Hopkins School of Public Health. I am not a health specialist. And I want to congratulate the work done by you and your colleagues for several reasons, and I think the work is very important for many reasons, but I want to focus on a few. And the first was that I like the fact that they utilize, among other sources of information, the information provided by defectors. There are tens of thousands of North Koreans in China, and there are some 20,000 in South Korea. And their numbers have steadily increased since the famine and the economic problems in the country. And they are a wealth of information on many issues, and they have first-hand experience of the healthcare system. There are some observers who question defector accounts because they say that these are out of date, they could be colored by emotion or distance or time, and political agendas. But in the area of healthcare, I think that describing one's access to healthcare and that of one's family and friends is quite different from giving opinions, say, about political issues or making recommendations about whether or not there should be military intervention in the country of origin from which the defector comes. Now, the information can't substitute for nationally representative surveys, but in a place like North Korea, which is often quite opaque on these issues and where people may not be able to speak freely, I don't think there could be a more reliable source of information than the people who have experienced the actual health system, and they're no longer in the country. And so I would take issue with the World Health Organization spokesperson who criticized Amnesty International's 2010 report on the health system in North Korea on the grounds that it relied on the testimony of people outside the country. And in fact, because of the potency of the information that defectors provide, the North Korean government frequently tries to discredit their accounts or may even retaliate against their family members or friends who are still in North Korea. Now, second, Gil Burnham's findings are important because they bring to light authentic accounts against a background of a lot of conflicting information and reports. Last year in April, the Director General, as many of you probably know, of the World Health Organization, Margaret Chan, who comes from the People's Republic of China, visited North Korea and publicly praised the government for providing universal free health coverage for its citizens and for having no lack of doctors or nurses. Yet, according to the UN Special Rapporteur on Human Rights in North Korea, Vitit Munterborn, and other UN officials, the hierarchical structure of the regime works to ensure that large numbers of North Koreans cannot easily access food and medical help. The elite, especially in the capital, have assured medical care, and probably it's reasonably effective. But for people in rural areas, that's another matter. The State Department's 2010 Human Rights Report says that access to effective health care in North Korea depends on one's political loyalty to the regime, which controls the medical and food distributions. Amnesty International has questioned the freeness of medical care, pointing out that gifts or bribes are needed for ill-paid doctors. Its report describes medical workers having to perform amputations without anesthesia and working by candlelight for payment in cigarettes in hospitals lacking essential medicine, heat, and power. Controversy also arose over the WHO Director General's emphasis on North Korea's, quote, notable public health achievements, end quote, which he said made it the envy of many other developing countries. Well, on malaria control and UNICEF vaccinations, there's no doubt been some progress. But the Secretary General of the United Nations, in his report to the General Assembly in 2010, emphasized that North Korea has a health care system in decline. Outdated water and sanitation infrastructure, inadequate medical supplies and equipment, combined with chronic food insecurity and high malnutrition rates. His report noted that life expectancy rates had shortened over the past 15 years, which Gil has pointed out, and that infant mortality and maternal mortality rates have risen, and used UN Population Fund statistics. In fact, Ban Ki-moon was alarmed enough to call upon the North Korean government, quote, to take immediate steps to ensure the enjoyment of the right to food, water, sanitation, and health, and to allocate greater budgetary resources to that end. Even more explicitly, the UN Special Rapporteur on Human Rights in North Korea strongly criticized the government's military-first policy for putting countless lives at risk by giving low priority to the population's health care and food needs. He called for a people's-first policy. And Amnesty International, on the basis of WHO findings, calculated that the government spends $1 per person per year on health care. Yet the North Korean government has boasted at UN meetings of its free universal medical care and its public health system and strategies, and countries friendly to it, like China, Myanmar, Belarus, Cuba, Vietnam, and Syria, have all publicly praised the government for its health system. Against this background, Johns Hopkins research is most welcome. Hopefully, it can contribute to a more credible foundation for understanding North Korea's health services, how the population accesses them, what the fault lines are, and where there are improvements. UNICEF, after all, is involved on the ground with immunizations and improving water and sanitation systems. WHO has helped with malaria control. And there are medical institutions and private groups in the United States that are engaged in trying to reduce the growing spread of tuberculosis. But as Gil mentioned, this is quite a serious problem developing. So an independent health school's findings could be important as a counterweight, when need be, to the data of international agencies which may or may not be credible or have to compromise with their North Korean hosts in order to maintain access. Furthermore, I would hope that Johns Hopkins research would venture into areas that go beyond the scope of the UN's data collection and collect information on the medical conditions in the penal labor camps in North Korea, where some 100,000 to 200,000 persons are held, in some cases for life, and where reports of starvation, denial of medicines, and high death rates are rampant. Third, Gill's findings are pertinent to policy choices on food aid that need to be made and are being debated right now by the United States government. Delivering food to North Korea strongly impacts on the health of the population, and Gill has strongly made that link. So we really should take a look at some of the arguments for and against delivering food aid. Many of North Korea's 24 million people are reported to face health problems that are related to chronic malnutrition, whether TB and anemia or other diseases. And even here, the WHO Director General begrudgingly admitted, she said, "I can see perhaps where malnutrition is an area where the government of North Korea has to pay attention." According to the World Food Program and UNICEF, there are some 6 million people in the country, or 1/4 of the population, who urgently need international food aid, and 5 American NGOs visited in February, including World Vision, Mercy Corps, and Samaritan's Purse. And they reported seeing acutely malnourished and stunted children and recommended emergency food aid no later than June. In some areas, North Koreans were said to be already consuming seeds and wild grasses. Without international food aid, health problems will skyrocket. The NGOs have called for food deliveries, in particular to hospitals and children's homes. So the debate in the United States on whether or not to resume food shipments very much hinges on whether the food aid will actually reach the needy people or whether it's going to be diverted to the military and the elite. However, the 5 American NGOs with long experience in North Korea claim they now have developed the kind of sophisticated tracking systems needed to ensure that food aid reaches the hungry. 2 years ago, they reportedly delivered food to some 900,000 North Koreans and had unprecedented levels of access, including Korean speakers on the ground, and were able to monitor at 24-hour notice food distributions from ports to warehouses to households. But even if the food aid reaches the most vulnerable, some argue it will still strengthen the regime by freeing up North Korean resources for other purposes. And of course, this could be true in part, but it presumes that without American aid, the North Korean government would devote its resources to the needs of its people, and the record hardly bears that out. Holding back the food aid will merely compound North Korea's neglect of its people. At bottom, the problem is the failure of the North Korean system. There are some who argue that denial of food aid might hasten the collapse of the regime. Kim Jong-il's failing health, the succession of his inexperienced son, and the loosening of internal controls could lead to North Korea's demise, so why should the U.S. help with food? But the premise is questionable. China seems ready to keep the North Korean regime afloat with at least minimal food and other aid, and more recently increasing investment. In any case, withholding food aid from starving people to help engineer collapse is hardly a policy the United States should be associated with. Of course, Pyongyang's nuclear program and its deadly provocations against the South in large measure explain U.S. reluctance to offer food aid. South Korea cut off its aid programs and didn't want the U.S. to provide food. But South Korea is now moving to resume food and medical aid, and in any event, U.S. policy should remain guided by its own values. These are embodied in the policy Hunger Knows No Politics, which the Reagan administration used to justify food aid to starving Ethiopians when they were under the thumb of a brutal communist and stridently anti-American regime. So in conclusion, I think we need to closely link the resumption of food aid to health care in the country. I think it would be a good idea to have a full study on the impact of food deficiency in North Korea on health, in North Korea. A good deal has been written about the impact on children of malnutrition, but I don't believe on the population at large. I would also recommend that the slogan, "No access, no aid," which has guided the food aid distribution, should also extend to medical aid. Systematic monitoring by NGOs and international organizations at health facilities would be valuable. I will stop there.
Thank you very much. All right, so we now have time for a number of questions. Actually, before we turn to the table, though, I don't know if there was anything in particular, Robert, that you wanted to come back on from Roberta's remarks.
Well, just a quick comment about cross-border diseases. And one of the examples of where there's been excellent cooperation has been with malaria. Because malaria just about disappeared from South Korea. It was a continuing problem in North Korea. There was a joint South Korea-North Korea control program for many years that did a great job in eliminating it, essentially as a public health problem.
Maybe I'll use the chair to ask the first question to Gilbert on the basis of what Roberta said. So, Roberta, you laid out the case that, oops, I'm supposed to use a mic, since all of you can't hear me from 10 feet away. You made the case against withholding food aid so as to hasten the demise of the regime, not to use hungry people as pawns in a political gambit. And that would seem to leave the alternative of trying to deliver, whether it's medical or food aid, that bypasses the central government systems and manages to reach the intended beneficiaries. I'm just wondering if Gilbert, you can, having visited various levels of the medical system, what you see as the feasibility, is there a potential for institutional collaboration between outside actors and county hospitals, say, to implement that kind of aid that bypasses the central government? That strikes me as ambitious, but...
I think the answer to that is probably no, but sometimes yes. And in the situation with tuberculosis, where there are huge problems with this multi-drug resistant tuberculosis, and only recently is there a lab in Pyongyang that can actually do the assessments, that there have been 3 American NGOs that have worked, kind of divided the country among themselves, and worked directly at the provincial and county level, and as I showed in the picture, provided medicines directly to the household. I think that works fairly well. One of the things that's critically important if you're providing drugs to the provincial or county level, just like food, is you've got to monitor these. And you do this by going to the market, seeing what's in the market and seeing what people are using for medicines and so forth. But one of the interesting things that's developed now is people not only bypass the small clinics, but they bypass the health system completely. They go down to the markets, they get diagnosed by the drug sellers, and so maybe you could argue that improving diagnostic skills in the drug sellers might be a good intervention. But there are a number of things that you can think of in this type of situation. But this is a very, very leaky system. I think at some level, it's not possible to work without major collaboration from the center, but there are perhaps avenues that one can get around that.
Yeah, I just would add that I have the impression that when the North Koreans do agree to allow the kind of monitoring that's insisted upon with the food aid, that a lot of it is allowed. Of course, you can't control 100%. But then when they begin to backtrack, then you can withdraw. And that happened 2 years ago when the United States withdrew its funding from the World Food Program, what was supposed to be something like 400,000 tons of grain, because the North Koreans were backtracking on the monitoring standards they had agreed to. So with the NGOs, however, they seem to have allowed more access and more adherence to the standards. So it's I don't think anyone can bypass the government, but it depends who is going to be allowing that kind of monitoring, and it's probably mixed. But the NGOs are quite confident that they can deliver the aid as long as what they agree upon is actually adhered to.
All right. Other questions?
Thanks for the presentation. It was really interesting, and you presented a lot, and it is depressing. I'm wondering if there's 2 or 3 maybe recommendations that you would have moving forward that could help improve health in North Korea, or if it's sort of if we're throwing our hands up and simply don't know what to do next.
Yeah, well, I think there's several things that one could say. Clearly, we start with nutrition. And one of the things that we've learned over the years, took us a long time to learn this, is that without adequate nutrition, you don't have good cognitive function. So it may be that a lot of bad policy on that side is made because people have just been malnourished for so long that they can't think straight about the issues. I think there's a couple areas that clearly need focus. One is the health workers. And building skills, building capacity, continuing education, and so forth. This could be done in a non-political way, just like that the NGOs and governments have learned in North Korea, have learned to trust each other on the aid monitoring and so forth. You could probably do that same kind of thing with continuing education, with support for medical and nursing schools, and so forth. So I think that's something that's a really low-hanging fruit. In negotiation, kind of health diplomacy, all this kind of stuff, but that's possible. Then I think the next phase would be looking at the drug supply, because every system is assessed by the availability of drugs, getting some kind of control over that. And when people have been asked, do you feel wrong about paying the doctors for this free medicine? And their response commonly is, well, the doctors have to make a living like the rest of us. So people understand how this happens. And getting some kind of standard approach, so people have to pay, but some type of quality control, some kind of price control, and so forth. So this gets into the market is another area. And then I think basically the infrastructure itself. Now that's the most expensive part. And the appetite for new equipment, for standby generators, for water systems, I mean, this is limitless. This is a bottomless pit. But you have to decide in some kind of coherent assessment, where do you start? And some of the international programs, like the Global Program on Vaccines, have started doing some of this health strengthening, health system strengthening kind of thing. But I would say that a clear assessment, maybe you couldn't do a whole assessment and pinpoint all the areas for reform, but at least picking out some priority areas and starting with those. And European Union, the Red Cross, Red Crescent Society, other groups are putting funds into these kind of programs. So that would make sense to do this in a comprehensive approach.
Anyone else? If not, I'll keep hogging the mic. I'll follow up after you. All right. So this is going to maybe sound like it's, a bizarre question, but here at CGD, we have a big research program on migration and migration as a tool of development. And so you've been using interviews with defectors as a way of getting a lens on what's going on in North Korea. But I'm just curious to ask you a little bit about defection as a phenomenon in and of itself. And I realize it's hard to come up with a comparable benchmark. Do you have an idea about how people are selecting into defection? Is it poorer people? Is it richer people? Is it sicker people, healthier people? And I'm not asking so as to evaluate the statistics about what's going on in North Korea. I'm curious about the defectors themselves. And then the follow-on would be, the flows of, you showed some, I think, numbers with the flows of defection. Is it possible to think about, in the medium term, this kind of emigration as a significant enough flow to be some sort of release valve on humanitarian conditions, as it is in other humanitarian disasters? Or are we just orders of magnitude away from it being relevant?
I think I want to pass that question to Roberta. I have lots of opinions, but I know you have really strong, long-standing opinions as well.
I can't say I have studied this, and give you that answer, but I can say that what's interesting when you first said migration is a tool of development, and I would love to know the statistics on this. North Koreans who leave or defect and go to South Korea and other places send back remittances, and I don't know the numbers, but they do get them back, and they get into, and I don't know how much profit is taken by the banks or whoever else in this process, but it does go back and apparently does get to families. I think there's somebody at USIP studying this, and it would be very interesting because that means their leaving brings back money into North Korea that actually can get, or most of it, to where it's supposed to, if that is what's happening. And I don't know, but I think it's interesting to look at and think about. As far as those who leave North Korea today and go into China, I believe that they are mostly women now. Largely it's economic, the reasons for going, although in some cases there's a thin line between the economics and the political reasons, and that a lot of them come from places that are near the Chinese border. There are provinces by the Chinese border. There are, on the release valve side, there are a good deal numbers of restrictions now with those leaving because, first of all, China has made restrictions on entry. So it's harder to bribe your way across or not get caught, and the Chinese generally send back the North Koreans and they're punished. So that already puts them as refugees as opposed to migrants. And the North Koreans have been trying to restrict very heavily now recently the numbers that leave or can get out. So the ones who get out, even in China, I mean, some of the women who are trafficked, who end up, working in the karaoke bars, they get money back into the country for their families, too. I don't have the kind of statistics you might want, but I think that's a general. But Amnesty International thinks that I don't remember that a certain percentage who leave are political cases, and that are going because they have been maltreated or otherwise either have become aware that life is better somewhere and they don't want to be subject to the kind of either persecution or life they're subjected to in North Korea, but that the vast majority of the cases are economic. And the release valve is a very, it depends, since they're going mostly to China, even though they make their way to South Korea, this will also depend then on Chinese policy, as well as North Korea's not wanting to admit that people want to get out of there. So it becomes, it's one of those rather sensitive mechanisms to evaluate in this case.
Thank you. Do we have another question here, and then we'll go to the back?
I would like to ask a question to Dr. Burnham. And in the case of food aid, there has been some limited mechanism in place as a result of years of negotiation between the United States government, the WFP, and the North Korean government, like 24 hours advance notice and several number of Korean speakers on the field. But in the case of medical aid, when I talk to these, several U.S. NGOs who are involved in providing generators or some medical equipment or drugs to North Korean hospitals, they say it's working well, but the details have not been brought to light to the public. So if you have any idea about, how monitors are doing their job, because, according to the many defectors, this TB, tuberculosis, or other many kinds of medical painkillers and stuff, they are in the black market and sold very expensively. So I strongly agree with Dr. Cohen's, agreement, insistence that it has to be go beyond food aid mechanism.
I just might add to that. Just about any place in the world where you're providing medical assistance in the form of pharmaceuticals or equipment and so forth, you have a monitoring system in place for that. And even if a country is not receiving much in assistance, they still have a monitoring system in place just for their own internal understanding of what's happening. So I don't think it would be too difficult to put this into place. And I think now with the precedence with the food program, that people understand on both sides how we monitor and so forth, that this type of monitoring for drugs would be possible. Now, where most of these drugs come from in the markets, some of them are smuggled, I think the majority of them are probably smuggled in, but the entrepreneurs know the patterns of diseases. So they know it's October, so we should be going to China to prepare ourselves for next summer's epidemics. And so they already, like a good public health system, this has evolved already. The market forces will start smuggling the drugs in, so at the time that these epidemics start, now the market's full of this, and we can meet the needs of the population. So there's a lot of things that would have to be done, I think, in that respect. I think, as Roberta mentioned, the migration is very interesting because the reason that there are so many Korean Chinese is, and indeed, this migration was a safety valve in the 1880s, 1890s. Whenever there was big famines in Korea, lots of populations moved to China where there were more food, and that's really the basis for that Korean Chinese population now. But it seems, at least from accounts, that there are brokers for migration in just about any area of North Korea now, so that you can, if you really want to go out of the country, you can find a broker without too much trouble. And periodically there are raids, and these brokers are brought in and so forth. But I think that's one of the reasons why also there's probably a smaller North Korean population in China now, is because this has become a system. This is kind of the underground railway, as it were. And people are gotten out from North Korea, and they can be in South Korea within a week or two afterwards. So they don't spend such long periods of time exposed to the Chinese police and others inside inside China.
Was there one more?
I was actually going to ask about migration too, but I'll ask a different question. The total fertility rate, I think you said, was 1.8. I'm wondering how readily available contraceptives are, and that's something that happens through the government, or if it's in the markets and people can access that on their own.
The official numbers for contraceptive prevalence rate, which means women of childbearing age who are using modern contraceptive methods, is around 60%. So it's fairly widely available. But it comes to this kind of, just as an aside, it comes to this migration issue as well. Because one thing we found with Cortland in our initial studies in the late 90s was that there was a huge amount of movement around inside North Korea. And the demographers call this churning, or demographic churning. People are looking for jobs, there's a lot of petty traders moving around and so forth. And one of the basic biological principles any place in the world is it takes two people to get pregnant. And if there's a lot of people moving around and a high fertility rate, and also, as we saw at the end of the Soviet Union, if you don't know what's happening with the future, this is not the time to have kids. And finally, there's another element, and that is if women are badly nourished, they don't ovulate, and so their ability to get pregnant is less as well. So there's many possible explanations, and I think all of them probably contribute in some way.
Economically, if North Korea had rational policy, they might, which they don't, they might see the advantage of North Koreans crossing the border and sending back remittances. But that flies in the face of their laws and policies which make it illegal. Brokers or no brokers, it's a violation of the law to leave without permission, and then you are punished when you come back. So their system for trying to control free movement of people, is really undermines, I would think, their whole their economic opportunities in this area.
But just to add a little bit to that, there has been this long tradition of Koreans in Siberia and Koreans in Central Asia. So there's these big colonies of Central Asia, and there is this Koreans working in the logging industry in Siberia, and they remit, whoever their employer is remits directly to government. And the same thing with Kaesong. That money goes directly to government. And I've seen estimates that the people working in this situation may only get 20% of what's actually remitted. So there is some element for that. And there are increasingly, at least the accounts I've read, groups of North Koreans working in construction, maybe Chinese construction companies in Africa. So this is maybe developing as a kind of long-term survival strategy.
Let me because just when you said that, this is quite a number of years ago, but when I was in West Africa, there were, these were our North Koreans, but these were, and I don't know if North Korea does this, but China used prisoners to build roads in Benin, and the ones who were building these roads, of course, I don't know if they were paid anything at all, but the China was able to underbid all the others who were wanting to get a contract there for the roads, and the workers themselves said, "We are prisoners. We are Chinese prisoners." And I actually put that in the New York Times, and then there was in Beijing they had a news conference, and where they denounced me as a rumor monger.
Monger, son. Yeah, there's a great story in Uganda where one of the prisoners got loose and fell in love with a Ugandan girl. Yeah, but I'll talk about that later.
All right. Well, unless we have any final comments from the floor, why don't we give a thank you to our two presenters for their remarks.